normally we have the sequence where we start with saying what is complex regional pain syndrome. For Dr. Schneider had to get out, so we'll kind of excuse him on that option over there. But so just out of sheer, raise your hands, how many of you are medical professionals here? So it's a smattering of them. So this is going to be something that I want that's going to have some medical information over there, but also for patients to understand what it is. And please feel free to ask questions, because I think knowledge is what makes us all understand or be able to cope with this process better. It's the ignorance of not knowing what it is, and it's just not the patients. I promise you that ignorance among us as medical professionals is so huge that I wish we could explain this to people and saying it's not all in the head, even though it is in your head. I mean, if you're a patient, you know it is in your head. So seriously. Anyways, I work as a consultant with Quest Diagnostics. Other than that, there's nothing there. So this is what Dr. Schneider said. This is something that is interesting, that it was in 1872 or something. That's when they first made a recording and reporting of this whole process over there. And since then, it's been going on. Now, it was categorized as being a rare disease process. So a rare disease process means that there are less than 200,000 patients with this condition over there. So we are quite special if you think in those terms. Now, what is it? And these pieces of information are going to coming up, they'll keep coming up to you over and over again. But essentially, it's an inflammatory and neuropathic pain process which affects the autonomic nervous system. What is the autonomic nervous system? So there are basically three types of nervous systems in your body. One is the motor, so what makes your hands go up and down. The second is the sensory, where you feel the touch and the pain and stuff like that. And the autonomic is the third one, which is where things like your heart and all that is beating by itself when you start sweating and all that. So it affects that process. And it is that reason why you see all these symptoms of swelling and color changes and all that is what you get to see. Now, for convenience purposes, they made this categorization as type 1 and type 2, but at the end of the day, it doesn't really matter whether you have a type 1 process or a type 2 process. The treatment options for both those are the same. So you can say what you want to, but at the end of the day, if you come to me, it's CRPS, it doesn't matter 1 or 2. Now, what is the epidemiology in this condition? That's the mean age. Now, I see, and I spoke to a few of you over here who have had children who have had CRPS. I've had that too, and I'm not advocating that I'm a pediatric specialist in any way. I usually only work with adults. Now, why you have such an incredible difference, 4-to-1, female to male ratio, I do not know the answer to that process over there. If it is something to do with an immune problem, maybe so, because we know that immune disease processes affect women more than they affect men. And there is an immune process going on in CRPS. So this is the same numbers that Dr. Schneider mentioned about the upper limb. Far more commonly seen in the upper limb than it is in the lower limb. And these are some of the conditions that we find CRPS associated with. Actually, I'm working with one of the surgeons, an orthopedic surgeon who's had knee surgery, and I just was working with him today, and he's got CRPS. And that is post-surgery. Now, this is a medical slide, but I mean, you guys are all patients over here, and all I can say is that I think that the fact that you're associated with, James and his association is really good, because if you look up his webpage, his webpage looks like a medical webpage. It's not like a advocacy page. It's got so much information in that I tell all my patients, I said, go back and read from there and then come back and tell me what you learned, because I may have missed something over there which I didn't keep up with what James is keeping up with. So this is, even though it's a medical process, but it is something that you look at and you say, hey, these things happen to people. Having a simple thing like lymphedema, you might have lymphedema and you go to the emergency room and all that they will tell you is that you have swelling in the leg, and go find out what are the reasons for swelling in the leg. But it is because of the fact that you've read about it, you know what it is, and you're going to tell them this is not the usual swelling, it is related to CRPS, and nobody knows what CRPS in the emergency room is. Very few people do. So you have that to worry about. Now, these were these things that they had made a mention about as to how would you make a diagnosis. Again, it's a medical slide. Initially, there was the IASP criteria, and then this came up, which is the far more solid criteria that we use. It's called the Budapest criteria. They all kind of went to Budapest, had a party, and they said, okay, let's kind of come up with something, how to kind of come up. This was the thing. No, they did have a party. What do you mean? But anyway. But this was the entire thing over there, and they said that you have to have one of the three of the following four categories and at least one sign in this process for the evaluation: sensory motor, pseudomotor, motor over there. It has helped us to say, if I can find a patient in which I can see all these things coming through, then to make a diagnosis becomes easier. Now, there isn't any particular test, and I'll tell you that also, but there isn't any particular test that we do in that we can make a diagnosis of CRPS, so people come around and tell you, oh, you can do this and you can do that. There is nothing definite. You know, if you take a plain x-ray and you have a fractured bone and your bone is broken over there, the x-ray shows you it's a broken bone, and you say, I have a broken bone. There is nothing like that you get to see which says, yes, this is happening over there, so you have complex regional pain syndrome. It doesn't happen. So that's the reason why getting to know what the criteria are, which is the Budapest criteria, has allowed for us to say we can, with an increasing amount of certainty, say, yes, we can make this diagnosis. What is the pathophysiology? I don't know. And this is an important thing for you to understand, that when a doctor says, I don't know, it's not because he's trying to be fresh or anything at all, because we don't know what is it that happens in CRPS. We know there are certain things that happen, but what is the actual process, we just don't know. But there's mention about small fiber neuropathy, there's mention about the sympathetic system that I talked about, inflammation and central sensitization. The central sensitization, this is something that is there, and this is part of the reason why I tell people that if you go to the emergency room, the only reason I'm making a mention about emergency room is because that's a place that you go to, and somebody says, you know, it's all in the head. It is truly in your head. And when I mean by truly in your head, it is because of this understanding that there is central sensitization, and I'll make a mention about this a little later. You saw this slide, so I'm not going to make a mention about this, but essentially tells you what happens over there. You have an injury, you get central sensitization, and this whole process keeps going up and up. There are all these different inflammatory modulators that are coming through, so this is a complicated slide. So these are the manifestations that you get to see. Now, I am sure if you look through these manifestations over here, you're going to raise your hand up and say, I have that. How many of you have pain? Everybody's got pain. We all get pain. I am in pain right now. If, you know, in my back, I was sitting in the car for a while, it's hurting. But it's not disproportionate to what I would expect. That is the part that you really remember over here. It is disproportionate to the intensity of the to the event that happened over there. This is what is different about the pain that you normally have. Okay, it is increased in pain in the limb in a dependent position. Have you seen that? Every often you will tell everybody, you know what, I like to lie in bed and put my leg up because I feel more comfort in that process. So you think about all these symptoms and say, hey, that's pain. Hyperesthesia. How often have you seen somebody walking into your office and you say, don't touch my hand, because they don't want you to touch that hand because that hand is so hypersensitive? That is the hyperesthesia that you have. So thermal. People have significant peripheral sensitization over there, so that when you go to shower, they'll put a leg out over there and shower. They don't want the cold water or the hot water to touch the leg. That is that process over there that happens. Weakness. This happens all the time. People come in over there, they start having to walk abnormally over there, and they start getting weakness in the legs, weakness in the muscles over there. Range of motion. Range of motion is reduced, and this is reduced because you're trying to protect your hand or you protect your leg over there. You protect your ankle. Tremors, you see these people over there? Have you seen that? That's myoclonus and dystonia are these abnormal movements that you get to see. Peripheral edema, very, very common. It happens in more than 80% of the people over there. Temperature and color variations, more than half the patients happen over there. And sweating abnormalities. How many of you have had this process over there where you're sitting and suddenly start sweating in half the body? I have this patient who comes to me and she tells me, she said she sits in the office and at work and suddenly half her body is sweating and everybody comes around and looks at her and says, what's the matter? I said, I don't know. Have you seen that? Have you had that happen to you? So what are the signs that you see which are trophic signs and symptoms? Abnormal hair growth. People come and tell you that their nails are falling off faster, their hair loss is happening over there, atrophy of the skin, muscle atrophy, fairly common, and contractures. Osteoporosis happens especially in the chronic stages. This is one thing that you get to see. This is one investigation that may be useful. It's not diagnostic, but useful to say, listen, are you getting osteoporotic? Because if you start having that happen, you start to treat the patients more aggressively. All right, so let's come to management guidelines. This is what we really are interested in. I mean, how do you manage the process over there? There is no one way to make a diagnosis other than what we talked about, the Budapest criteria over there. But the basic goal that you're looking at is to try and control the pain and maintain function. If you can maintain function for any patient with CRPS, they are delighted. It is because that lack of function, so they can't go to work. Once they can't go to work, there are all these social issues that happen over there. You got a 40-year-old female, can't go to work. She loses her economic freedom over there. It's a huge process. So trying to maintain function, that should be our basic control, is how do you control pain and how do you manage function. Functional improvement, this can happen long before pain control can happen. So suddenly you see that they are doing well over there, the patients get around, they're walking around, but they're still complaining about a pain scale of 8 or 10. Now, like I said, there are no practice guidelines, no specific tests, no cure for the condition, but we should hopefully be able to control it and keep it under some kind of remission. Symptom remissions may happen with variable durations. Early intervention results in best results. I was just talking to somebody, that I'm taking care of this doctor over there. He's an orthopedic surgeon, had knee surgery. He called me up and he said, I need your help. I said, what's happened? He said, I'm having such uncontrolled pain. In 3 months, he's had 4 knee surgeries. Now he's got crips on his leg. And this is a gentleman who does total joint surgeries, so he stands and works. When he came to my office, he couldn't sit. He said, I cannot sit. So what did I do? I immediately started, I said, I'm going to set you up and start doing some sympathetic plexus blocks. So I've done 3 of them for him, started him on a small dose of gabapentin. I used Grelise, the long-acting medication. He just sent me a text today. He said he's back to surgery on Tuesday next week. This is in a matter of, I only did 3 injections. I have not done a lot, but that was an early case. So early interventions, if anybody gets to see this or you know somebody that's happening, quickly look for help and say, can you get this? If something can be done early, you're likely to get better results than if you hang around for a long time. And multidisciplinary approach, this is the best way to get things done, especially when the situation starts to get more chronic. All right? Okay, this is just a very busy slide, but this is because I just had a call today. One of my patients is having surgery today, and she's having a cholecystectomy done today. She's got crips. And the anesthesiologist called and said, hey, listen, what do I do? So I just told them, I said, you need to give some intraoperative ketamine, but this is an important thing for you to understand, that in your lifetime, you probably will need surgery sometime. I hope you don't, but if you do, it is to keep in mind that you need to have some kind of a plan. How do you kind of take care of that? Medication categories, I'm not going to go through this whole process over there, but anti-inflammatory medications are used. I use this more so in this high dose process over there. I use celecoxib or ibuprofen, but I give them very high dose. I don't like using steroids. Steroids are good, but not so good. So I use ibuprofen, which is actually quite cheap and quite easy to afford. 800 milligrams 3 times a day for 3 to 5 days, acts as an anti-inflammatory, helps you get your things back in control over there. Various neuropathic pain medications, you can go through the list over there, gabapentin, Grelise, whatever. And none of them are the best medication. Everybody can try whatever. Anticonvulsants, triliptol, levetiracetam, Keppra, whatever. Muscle relaxants. This is actually quite beneficial because dystonia is a big problem with patients over there. So using a drug like baclofen helps a lot. Calcium, sodium channel blockers, anxiolytics, antidepressants, calcium channel blockers. Calcitonin. Calcitonin is an interesting drug which I use quite extensively. It's a nasal spray. And it helps with this anti-hypoanalgesic effect over there. Why? I have no idea why it works, but it works and it doesn't have any side effects. Now, opioids, not the preferred choice of drugs, but in an acute situation, yes, you would do that. But what you have to understand is that we talked about this central sensitization. Opioids will actually cause further central sensitization by activation of the glial cells. So you really don't want to use that if you're having a lot of neuropathic pain processes. This is a big issue. Short-acting opioids may benefit patients over there. Now, we're talking about interventions. Stellate ganglion nerve blocks is something that you do in the neck for people with upper extremity CRPS. It is done around that C6 vertebrae over there. You do it under fluoroscopy. There are a lot of blood vessels around there, so it needs to be done by somebody who knows what needs to be done over there. And I recommend this 2 times a week for about 2 to 3 weeks, and this breaks the pain cycle. Once the CRPS has been around for a while, it's really not helpful. Now, Exparel, this is a drug that's, bupivacaine is a local anesthetic, and Exparel is how it's delivered, and it's a long-acting local anesthetic, lasts for about 3 to 5 days. Now, this got approved actually for use when people are having hemorrhoid surgeries. You know what hemorrhoids are, right? That's a pain, where, sorry. But I use this for people with CRPS because it gives you a block for 3 days. So when people have long-time block over there, they are so much more encouraged rather than just for a few hours. So that's how a stellate ganglion block is done. You can see the needle over there. This is the C6 vertebrae. You can see the rib coming out over there, clavicle. And this is the contrast that goes into that place over there. And when you get that, pretty good relief. The same thing happens with the lumbar sympathetic plexus block. This is for the lower extremities over there. I usually tend to put 2 needles, same thing. I like physical therapy to be done at the same time. And that's what you do. You get 1 needle coming over here, 1 needle coming over here. This is L2, this is L4. Put a little bit of contrast, and you put a lot of local anesthetic. So let's talk about the other 2 things that I do in my office, which are actually quite interesting. Naltrexone. Anybody over here on Naltrexone? Low-dose Naltrexone? Nobody's taking? Yeah. 2. Couple of them. 3 of them. So low-dose Naltrexone is actually an interesting drug, and I've been using it for the last 5 years, and I am blown away. I've been doing pain management for more than 30 plus years, and this has come as a complete wow. Naltrexone is a pure mu receptor antagonist, and for people who are using it know that this is used for people when you have an opioid overdosage. That's what you use. It's been around since the 80s. It's now approved for alcohol and opioid addiction, available as Vivitrol. Please don't confuse Naltrexone and Vivitrol. Please don't confuse Contra with Naltrexone that we're using, okay? Now, how does it work? It's usually administered at about that dose we start with. It's a compounded medication. The way it works, and I explain this to my patients, that when you give a prescription drug like Naltrexone, it comes and sits on the receptor. And when you take heroin, Naltrexone prevents the heroin from working on that receptor. But when you give it in a small amount, the Naltrexone gets washed off. That receptor now is inducing the brain to release endorphins. And those endorphins are what are your natural painkillers. That's what happens over there. It acts, that's the central sensitization what we were talking about. And this is a technical term, TLR receptor. It's called toll-like receptor. The Germans were kind of doing research over there. They didn't know what to say, so they called it toll. So that's why it's called toll-like receptors. But anyway, so this is part of the central sensitization process. And when you give Naltrexone, it actually reverses that process. So when you give a lot of opioids to patients, it causes central sensitization. You're able to kind of reverse that central sensitization by using Naltrexone. In addition, it blocks the production of a cytokinin. This is cytokinins are chemicals that cause swelling. It actually acts as an anti-inflammatory, so it's very useful. And this is the best thing that happens over there. It causes an enormous amount of boost in your T cell count, which is what the immune process that we know is involved in CRPS. So we've done about 450 patients over there. It's been very successful, 70% response rate. Response in a week, month, 3 months. This is something that's important, that it might take a few months before you see the response over there. I've had people who've been on prescription pain medications for 25 years. We've stopped them over there. I've had patients, intrathecal pumps I've removed over there. Really no side effects to worry about. Sometimes people have a headache, which is common enough. Sometimes they can't sleep. And it costs about $15 a month. So I'm sure the pharmaceutical industry is very upset with me because now I've taken away a lot of business with them, Ketamine. This is the other thing that I do in my office over there. Now, anybody over here has had ketamine infusions? Wow, pretty big amount. Okay. Ketamine is an anesthetic drug. It's been around since the 1960s, okay? And if anybody knows what ketamine is, it's the cousin for angel dust, PCPs. So it's a hallucinogenic agent, okay? So when we started using it, I've been doing anesthesia since the 1980s, so I've used ketamine extensively. But it's a pretty good drug. It's very safe for cardiac and respiratory systems over there, but it has many side effects, okay? These are all the side effects that you have in ketamine. Now, what happened with ketamine since the 1990s? This is a gentleman, Graham Correll, is the one who initially introduced ketamine in Australia. He came to the USA, talked about it to Ron Hubbard, who then came and spoke to Robert Schwartzman. So even though Schwartzman gets a lot of credit for the ketamine, it is not him who initially started it in the US, it's Ron Hubbard who started it. But Robert Schwartzman really popularized the process. Done outpatient, inpatient, ketamine coma, not recommended, not done in the USA. I have one patient of mine who went to Germany for a ketamine coma, and she did well, but then the symptoms all came back. It requires supervision. You need to be monitored. All right? Now, this is the usual process that we do for ketamine, history and physical, use the criteria for that, no investigations, evaluation by cardiologists, psychologists. Presence of severe psychological issues don't do it. I had one patient who came to me and the psychological evaluation was done by somebody who I didn't know who the psychologist was, said, it's okay. I gave her ketamine the first time, second time, third time, I get a call from the police station. She's sleepwalking. I said, that's not such a good thing to do. And she's going home and she's sleepwalking on the street. I said, okay, maybe one time. I did it one more time. Again, I said, okay, no more ketamine. I can't have this woman getting driven over by a truck because she's sleepwalking. So I stopped it. I mean, that was a bad thing for me. Okay, we like to perform all your SMSCs and LFTs before we do that. This is our outpatient setup over there. We have all the resuscitation equipment. What has been our protocol? This is the protocol that we use, which is what was set up by Schwartzman. It's been pretty good, not a problem at all. And 5 days, 2 days, stuff like that. Okay, now what we have had is we have been able to modify the technique because we can add lidocaine if we think it's helpful. We add magnesium. Some people have had a lot of success with IVIGs. We have added bisphosphonates. We've also added acetaminophen. Acetaminophen given intravenously is a powerful anti-inflammatory, and it's been pretty good. So what has been our experience in 7 years? We have done about 100 patients and about 2,700 sessions. And these are the drugs we've used over there. And these are the side effects. We did a little retrospective study, analysis. And the only thing I'm going to tell you about this whole thing was that the PGIC, which is the patient's global impression of change, was 4.65. This is on a scale of 0 to 7, where 7 is complete resolution. So that is about 65%. And inpatient protocol is a lot more difficult. I don't do that. It's not recommended, but you can do it for 5 days at a time. Physical therapy. I don't know if anybody's speaking for physical therapy today. All right. Physical therapy is mandatory in the management of complex regional pain syndrome. If you're going to a doctor and they're not recommending physical therapy, ask for physical therapy. And hopefully you can find a physical therapist who knows what complex regional pain syndrome is, because it's not, the treatment is not the same like for regular people who have had back surgery or limb surgery or whatever it is. So just be careful. But it is really, really important that you start it, and you must continue with it as long as you need. Some people with CRPS need physical therapy for years because you need to maintain their function. But it is important that you do this. Multiple modalities are used for this process over there, and that is what you're looking at, is to maintain function. I had this patient who came to me from Delaware. She had a total knee replacement done. They didn't send her for physical therapy. Her knee got fixed. So they went back and they took out the old knee, put a new one in, and they forgot to send her for physical therapy. I said, you did it a second time, you didn't do that. So she came now in CRPS with a rigid knee, had an intrathecal pump in place. We kind of worked her out to try and see if we could help her over there. Finally, we took the intrathecal pump out on Naltrexone. Now she's had stem cells put in after a third knee replacement, stem cells put into her knee joint, and now I can't control her pain because she does not respond to any opioids. So yesterday I saw her and I said, okay, let's try some oral ketamine and see if that makes a difference. And I don't know if it'll help or not, but it is really a significant problem that if you're not doing therapy at an early stage, you're going to have problems over there. Other options, we talked about the stimulator. There are other types of stimulators that are available in the market right now, and there's a choice that you can think in terms of. Intrathecal pumps, I do a lot of them, but I don't think this is going to hang around for CRPS. Thank you very much.